All right, good afternoon, everyone. Welcome back from lunch. My name is Megan King. I use she, her pronouns, and I'm one of the organizers of the series from the Washington Poison Center. Before I turn the session over to Dr. Winstead and Allison, I have a few housekeeping items to go through. This session is being recorded. We will make all recordings and slides available by early next week. In order to earn your certificate of attendance, you must watch a minimum of 5 live or recorded sessions by September 15th. As a reminder, we are not able to provide CEs or CEUs, just that certificate of attendance. Please ask us your questions in the Q&A tab on the right-hand side of the screen if you're watching through Whova. If you're watching through Zoom, you are welcome to place your questions and comments in the chat box. Dr. Winstead and Allison will answer questions at the end, but please pop them into the Q&A tab or the chat box as you think of them, and if they're clarifying questions, we'll be sure to address those throughout. So that is it for housekeeping. Now I get the pleasure of introducing our two speakers, Dr. Teresa Winstead and Allison. Dr. Winstead is a research scientist with the University of Washington Medical School, in the Addictions, Drug, and Alcohol Institute, and she's an associate professor of anthropology and sociology at St. Martin's University, where she is chair of the Department of Society and Social Justice. Her research focuses on harm reduction practices related to substance use. Allison Newman is also at the University of Washington's Addictions, Drug, and Alcohol Institute. She provides training and education on overdose, opioids, and works on the website stopoverdose.org and learnabouttreatment.org. If you've never been to those websites, they are fantastic. I feel like I use them on a daily or almost daily basis. Allison specializes in health education and healthcare access around drug use and health. Thank you both for being here today and for participating in our series again. I think it's either Allison's third or fourth year of doing this with us. So we're very, very happy to have her here and to have Dr. Winstead joining her today. Thank you both. I will turn it over to you now.
Hi, everyone. Thanks so much for joining us. Our topic today is unmet needs. Let's see. Complex motivations and an ideal care for people using fentanyl in Washington State, a qualitative study. I want to have a quick shout out to our two co-collaborators on this, Everett Maroon and Caleb Bantagreen, who conducted interviews or helped with the analysis on this. We'll dive into the report shortly, but really we're going to talk about scope, background, methods, who we talk to, findings, discussion, recommendations, and limitations, and a big thank you to everyone that we worked with. So as I said, here's the things we're going to talk about. So methods, topic areas that we looked at, what our approach was, background, and who our partners were. So I'm going to hand it over to Teresa.
Great. Thank you so much, Allison. We are super happy to be here with you all to share the findings from this project. And we want to start with thank you to our partners, the syringe service programs and their participants who helped make this possible. The sites that we worked with are listed here. We'll talk a little bit more about them as we move into the methods of the project, but we worked with the syringe service program in Port Angeles, Tacoma. We worked with two sites in Tacoma, the mobile exchange and the brick and mortar site of the needle exchange, the Thurston County syringe service program in Olympia, and Spokane's regional health district syringe service program. So huge thank you to the sites for helping us with recruitment and sharing their space with us, and the participants for sharing their insights and experiences to help make this whole thing possible. We all know that the opioid overdose epidemic continues to rise and is primarily driven by unregulated fentanyl. From 2019 to 2022, the overdose death rate in Washington more than doubled. The dominance of fentanyl over heroin is the primary opioid in the illicit drug supply. It's fundamentally changed the context of opioid use, increased our overdose risk, intensified the need for social and medical support, and it's why we're focusing on fentanyl, of course, in this, this project. All of this underscores the need for work like we're sharing today, that really brings the voices of the people who know the most about the landscape of this crisis to help better inform interventions and strategies to prevent overdose. This work builds on other projects that ADAI has done with syringe service programs. And this is the third qualitative project that ADAI has fostered. So the other work that ADAI has done is all available on the ADAI website. And if folks are interested in those connections, we can provide those as we go through the discussion today. I want to take a minute to recognize and sort of call out that the approach of this project and the design of it is all informed by the principles of harm reduction. We seek to inform policies and decrease harms of fentanyl by engaging with people who are using fentanyl, who naturally know the most about their needs and what might work to improve their wellness, and really emphasizing that their insights are valuable and important. The interviews were exploratory and semi-structured and designed with the principles of trauma-informed communication, with attention to fostering dialogue that's caring and respectful, and really creating a space of generous connection and compassion. So as Allison mentioned, we covered a lot in these interviews. The topic areas that, that the interview touched on include treatment history and experiences that people have had, fentanyl use and other substance use patterns, motivations and drawbacks of fentanyl use, so sort of why and what people are thinking about in terms of their fentanyl use, individuals' interest in stopping or reducing their fentanyl use, and then really importantly for this conversation, preferred services and ideal care. And so we'll share all of that as we move through our findings. Hope we can, yeah, thanks, Allison. The methods for this project were, as I mentioned, qualitative, so semi-structured interviews, and we conducted those interviews from September to October in 2022, so last fall. Participants were offered a small gift card for participating in the research, as well as snacks and drinks. We had Capri Sun and bubble water for folks. We did capture audio recordings of all of the interviews, and those were transcribed by a HIPAA-compliant transcription service. And then they were verified by the research team. We spent a lot of time making sure that what was on our transcripts was accurate. When we began analysis, we used a combination of strategies for coding the data, which included structural coding based on the interview questions, deductive coding based on things we already knew that we were interested in, and inductive coding, where we tagged things in the data that we wanted to make sure we captured. So a combination of those different strategies. We used MaxQDA, a qualitative research software analysis package to do the analysis. And we had a lot of discussions over the course of our analysis time, talking about kind of how to interpret the findings. So iterative and reflexive process throughout. We shared the research back to the sites before we published the official report through ADAI, in order to offer an opportunity for sites to give us feedback on the report. And we also created a handout to be shared with participants before the official report was completed. So that's kind of the basics on the methods. The screening criteria we used to select participants includes being a current syringe service program participant, first off, being over 18 years old and having used fentanyl at least 3 times in the last week. And talk about, I think, Allison, if you'll advance the slide, we can talk about demographics next. We want you to sort of have in mind the demographic characteristics of our population as we talk about our findings. So I'll share a little bit about that. First off, for those of you that may not have the geography of our sites in mind, we wanted to just offer that we interviewed 14 respondents from the Tacoma Syringe Service Program, 8 from Olympia, down at the tip of the Puget Sound. Up in Port Angeles, we had 4 respondents, up on the north, in the north corner, and in Spokane on the east side, we had 4 respondents. And then looking at demographics more specifically, I'll just call out some things to pay attention to. Over half of our participants reported white as their racial and ethnic identity. 73% of our participants were male. The mean age of participants was 37, and only about 13% of our participants had stable housing. So meaning 83%, 73% were unhoused, 13 of those reported, 13% also reported unstable housing. So just a note to really think about that housing stability as a piece of what's going on for the folks that we talk to. We can go to the next slide. Thanks, Allison. In terms of fentanyl use and fentanyl use patterns, we ask about frequency and duration of fentanyl use, and you can see the vast majority were using fentanyl every day, so 7 days a week. 83% of the folks we talked to had daily use, and the mean duration of their use was about 13 months. So, so that shift in the drug supply to predominantly fentanyl is sort of echoed in that data. Yeah, and nearly all of our participants used other substances in addition to their fentanyl use. That's good. And then treatment history, when we asked people what their previous treatment experiences had been, what they had experienced, 2/3 of our interviewees had tried some kind of treatment, with the majority of those having tried non-prescribed buprenorphine. So outside of the healthcare system from a friend or other source. Responses about traditional treatment experiences were mixed and often negative. Frustrations accessing treatment were documented in a lot of our data, in a lot of our use. So one participant in particular, the quote that's here on this slide, shared his frustration with accessing treatment. When he replied to the last question in our interview, we asked him, you know, what else do we need to know about supporting people that are currently using fentanyl? And he said, when people get sick, when they do get sick and they say they're sick, take pity on them. Don't say, come back tomorrow. That's a million miles away. Do something, help them get well and tell them that's it. And then this sort of message for us was underscored by his own experience trying to access treatment, which he described just after this. He said, I take a bus to the methadone clinic. I was 15 minutes late and the provider wouldn't give me my dose. I thank God she didn't give me my dose. I'd rather take drugs. So just underscoring the complexity of access and the difficulties sort of inherent in accessing daily methadone. We'll talk about findings. I'll share sort of the first half of our findings, and then I'll hand it over to Allison, she'll talk about the rest of them. So the first kind of piece of this, the general findings, is how are people using fentanyl? And then we'll talk about the other categories here after that, sorry. How and why, how interested they're in stopping or reducing their fentanyl use. And then again, we'll get to ideal care. So I'll start with how. Most people, our participants, started their fentanyl use with smoking and maintained that as their primary method of use. And they noted this rapid shift in the supply from heroin to fentanyl. A few of our participants reported injecting, or actually quite a number of our participants reported injecting heroin, but had discontinued injection and had switched to smoking fentanyl. This participant noted the following about his transition to smoking. Every one of my friends that started using fentanyl after heroin has stopped shooting up. We shoot up more rarely now than we ever used to. I used to use once a day, and I've been using once a day for 15 years. is a lot easier, not having to hit yourself. You just grab a piece of foil when smoking, and it's a little easier way to receive. So just, I think that's a significant part of our, what we learned from participants, that they really, a lot of transition to smoking as a primary mode of ingestion. And they had, we can go ahead to the next slide. Thank you, Allison. We had people report really complex reasons for preferring smoking. Like the previous participant noted, easier than injecting was one. But they also, folks talked about control of dosage and experience. Overdose risk management was another significant thing that people shared about preferring smoking. They wanted to avoid the health risks of injecting as well. So it's important to note that our the engagement in risk management through choosing to smoke, in part because we're still seeing such an incredibly high overdose rate with all fentanyl use. So this participant sort of echoes that concern about injecting, and they say, I'm just too scared to shoot it, because there's been a lot of people that have had, even with melting pills down to shoot them, they've overdosed off one pill and they're dead, even though they have been on it for years. So I'm too terrified to do it that way. I'm not looking to die. I'm just looking for some pain relief. Again, respondents talked a lot about the rapid shift in the drug market from heroin to fentanyl and how this change affected their use, their substance use. At the time of these interviews, respondents were knowingly and intentionally using fentanyl. So that's another thing to sort of note about this population and this project, rather than using it unknowingly or mixed with other drugs. These two participants reflected on the effect of the shift to fentanyl that had on their opioid use and their overdose risk. So I'll just read the first one here. It's a mess, but at the time I thought it was a good idea switching from heroin to that. It wasn't a good idea. I should have just stuck with heroin because I wasn't dying from heroin. So our participants were asked to talk about why they used fentanyl. We asked them to talk a little bit about why they use fentanyl and to describe the benefits and drawbacks of their fentanyl use. That's how the question sounded. And they described a lot of reasons for why they use fentanyl, which were often overlapping and interrelated. Importantly, the reasons reflected a complex interplay of the themes that we'll share today. So we have here on this slide, kind of in green on the side, a lot of the reasons that people talked about for using fentanyl, and the drawbacks are in red on the other side. So physical pain management was reported as a significant theme, mental health and trauma as a reason for using fentanyl, and reasons related to housing and economic insecurity. And then in terms of drawbacks, as you can see, the role both of the drug supply changes, overdose risk, and the impact on relationships, goals, and efforts to take care of themselves. Those are the drawbacks of their fentanyl use as main themes from our interviews. And I'll give some examples and talk through these main themes. In terms of physical pain, this was a major reason respondents reported using fentanyl. 70% of our participants cited pain as the reason pain management as the reason they were using fentanyl. There was an emphasis on chronic pain management. People mentioned osteoarthritis, diabetes-related pain, traumatic injuries from work accidents or car crashes. They explained that the benefit of their fentanyl use, again, was its ability to control their severe chronic pain. And this first participant says, it's not just because of withdrawal. I'm dealing with these pain issues that I have. I have to do fentanyl or else I can't even get out of my car and go and pick up the kids or go play with the grandkids or whatever. I can't do these things if I'm in pain, and fentanyl definitely takes care of the pain. And this next participant says, if it wasn't for the pain, I wouldn't be doing fentanyl at all. And the last one shares, I don't care either way, other than the fact that I would prefer it if I could actually get some pain relief from a doctor without any shit. So just sort of an undercurrent about access to medical care around pain emerging in those quotes. The second major theme in terms of why people are using fentanyl is mental health. A few examples here of how people are talking about fentanyl related to their mental health. They talk about managing mood and mood symptoms, negative self-image, previous trauma, difficult life circumstances as a motivation for fentanyl use. All of these things sort of emerged from this section of our interviews. Fentanyl was described as a strategy to create a feeling of numbness or calming, and as a way to either block out previous trauma or cope with difficult circumstances. So this participant says, I seek it to numb myself. I'm 28 years old and I've been through more shit than a 56-year-old woman. And it's complicated because there's certain shit I'm blocking out that I'm not ready to deal with yet. But if I keep letting it destroy my life like this, I'm going to die within the next week. I don't want that to happen. So I called to get into treatment today. So just profound sort of response to mental health challenges. There's another example here, I think in the next slide, related to mental health. I use fentanyl for mental stability. This participant says a kind of mental security to where I'm not just bouncing off the walls. And this last participant shares, it's self-medicating. It's a preferred medication to have for self-medicating for myself, for trauma that I've had or whatever else I'm trying to get rid of. Yeah, thank you, Allison. The last theme that we'll share related to why people are using fentanyl is related to housing insecurity. And as I mentioned, a lot of our participants were struggling with housing security in this population. As with pain control and mental health, connections between housing and fentanyl use were really complex. And some participants mentioned that fentanyl was the cause of their housing insecurity, and others talked about how fentanyl was a way to cope with the fact of response to living without housing. So our participants explained this kind of combination effect of being homeless and needing fentanyl on a daily basis really kept them in a cycle of sort of repeated and a high degree of chaos. They liken their fentanyl use to a full-time occupation, leaving little time for other pursuits. So you can read the first quote. The second quote, my homelessness is definitely due to fentanyl use. I don't work to do anything with myself at all. So pretty much just, I couldn't think about going to work because what if I don't have all of the dope that I needed and I'm trying not to be sick at work. The last participant says, it makes life easier, makes it to where you don't feel the bullshit. You don't care. You don't care about none of the shit related to housing. You don't care about it and it helps. So just that sort of really complex relationship between housing and fentanyl use that a lot of our participants pointed to. And thinking about the drawbacks now of, oh, actually, sorry, this is still a reason that people cite it for using fentanyl. Of course, right, naturally, participants talked about withdrawal as it came up. As a reason that they continue to use fentanyl. So this first participant says, honestly, I use it because so I'm not having the sickness every day. You have to, or you're going to feel like shit. So basically pretty much why I use it and have used it for God knows how long. The fear of sickness is just, it's not fun. It's not something anyone wants to go through. And then the second quote, the second reason for my fentanyl use would just be dependency or addiction. Coupled together, it doesn't seem completely realistic to stop using without some sort of replacement or alternative. And I think, do we have a question?
Yeah, I think Megan had a question. Let's see. It was, did you all ask about alternative non-pharmaceutical efforts to manage pain in this population, maybe prior to becoming reliant on fentanyl?
We did not.
Yeah, we didn't ask necessarily, we asked about when people started fentanyl, but we didn't dive too much in to what medical or alternative treatments people had had. I think this finding around physical pain was not completely surprising, but I think we were struck by how common that was as a response.
Yeah. Yeah, and it did. So frustration with accessing medical care did come up a lot. Not as much as these other themes that we're talking about, but when people were talking about their pain, often they would mention not being able to access care from a doctor or being treated poorly by a doctor or in a medical environment that made it feel like there wasn't a practical option. Thank you for the question.
Thanks for the question.
So yes, of course, withdrawal. And then moving to overdose risk. I think we can go to the next though. These are the not the benefits, the drawbacks of fentanyl use that people talked about when we asked them to sort of think about the pluses and minuses of their fentanyl use. Of course, people talked a lot about overdose risk. So these two participants say it's killing way too many people, good people who don't deserve to die, and it makes you a prisoner to the drug. And then the second person says, but the high isn't even the same. It's not as euphoric. Heroin actually, you felt the effects of, but this stuff is just, if you do too much, then you're going to overdose. And the line is really, really small there. With heroin, it wasn't that. You could get away with a lot more than with fentanyl. With fentanyl, there's a very tight, if you do a little bit too much, you're going to overdose. And you don't have somebody, if you don't have someone there with you, then sayonara. So overdose risk was emphasized across our interviews.
Teresa, can I interrupt you with a couple somewhat related questions to
Yes,
this?
please. Yes.
So there are a couple questions here that's talking about perception that overdose risk is lower with smoking versus injection. Wondering if you can speak to that a little bit, if participants brought this up at all, and also maybe talk a little bit about what the actual science is behind that.
Yeah, and Allison, you should chime in as well. Yeah, the smoking, emphasis on smoking for sure is concerning. And I think the question is there needs to be more research done about kind of how to mitigate overdose risk and when people are primarily smoking. I think the heart of the question, Megan, you might help me make sure I'm answering it, but we're really careful not to say that overdose risk is decreased with smoking. The drug supply is so variable, so toxic, that there's no way to say that. We still are seeing really high numbers of people that are overdosing, and smoking is the modality that they've been using fentanyl with in those cases. So super complex, and we just need to lean into, I think, developing more research around smoking and decreasing overdose risk, and education campaigns around how to mitigate overdose risk with smoking. But just to bring it back to our participants, we did hear people say a good number of times. I think we have 6 participants in our findings that talk about the reason that they're smoking is that they feel it's less of a risky way to use fentanyl.
And so with the science behind it, I mean, the most important, the amount of fentanyl in the drug supply is hugely, hugely variable. So let's say hypothetically smoking was a lower risk. It might not matter given that sometimes the amount of fentanyl in the substance someone's taking in is so high. So, people did talk about being able to break up the pills into smaller amounts and use do what we recommend, which is do a small amount, a tester amount, and that's easier with a pill than with injecting. So there were ways that people were able to better regulate the amount of the substance that they were taking in. But we just have a really dangerous drug supply where, one one pill could be barely enough to help someone avoid withdrawal, and one could be more than enough to cause an overdose and potentially kill someone. So there's sort of two factors going on that make it hard to say whether smoking is safer or not, but we can really clearly say smoking still can cause overdose and death, and that we need to help educate people on this topic.
Thank you, Allison. Yeah, super, super important. Megan, was that all?
Yep, go ahead. We can save the other two questions until the end.
Okay, yeah, I think I almost remember that there were other questions there, but thank you for tracking those. And yes, let's take care of them at the end. And right, so overdose, back to the slides here, overdose risk is definitely a concern for participants. And I think we can move on to the next slide. As Allison was just saying, echoing, this is echoed in our participant data, concerns about the variability in the supply. No, right? Our participants know that they're navigating a really dangerous supply, and they talked about it related to overdose risk. So this participant says, because the problems, it's because of the pills and they can vary in strength, whether the mixture, whether it's cut because of on purpose or just an accident, and how it's stirred together. People with low tolerances aren't used to it. So when they have it and they're used to having some pills that are strong and some that are weak, they're going to overdose because they're just not used to it it was at a set level, like where you're getting it from a dispensary where it was professionally done in a set level. They would know what they were getting, and then those people wouldn't have that problem. So just a lot of documentation of just the variability being presenting a really huge challenge for people trying to keep themselves safe. And then people talked about drawback of fentanyl use, focusing on relationships and goals. And this participant says, my family definitely looks at me differently because of it. I don't know, they get scared and shit, but they're all scared of me doing it. And I never expected my life to be like this. And this participant had an accident when he was younger, and yeah, found himself in chronic fentanyl use. And yeah, just the repercussions are on relationships were significant. I think one more on negative effects of relationships. This person shared, I feel more comfortable going to a tent to get high rather than going to my mom's house or going to one of my family members' houses and getting high. It consumes you. It makes you think that you're all alone in this world. The only thing that's going to help you in the dark fucking world is that drug. So just a lot of obviously strong feelings about how fentanyl can really take over. And I think this is about where I'm handing over to Allison, who'll talk about how our participants responded related to their interest in stopping and reducing their fentanyl use, and what their visions and needs were related to ideal care to support their health. Go ahead, Allison.
So, yeah, thank you, Teresa. So we asked everyone, how interested are you in reducing or stopping your fentanyl use? And this is a question we've asked previously on our statewide syringe services program survey. And in this particular group of people, 70% were interested in reducing or stopping their fentanyl use, 27% were not interested, and 3% were not sure. But something really important to note in this is that many of the people who are not interested, it was because they saw significant barriers to being able to reduce or stop, like not being able to find the treatment they needed, not, having tried different options before and not having them be effective, feeling like there might not be anything to help address their pain or housing, or, similarly, really feeling like they would need to have other things in order before they addressed it. People perceiving that there are significant barriers to them being able to improve either other areas of their life or find a treatment that would be effective for them. But I do think it's really important to note most people were interested in reducing or stopping their use. So one thing we did that I really like about this qualitative study is we did ask people about what services they would want if they were easy to get and what ideal care would look for them. Just a summary of that people really wanted a big range of different physical and mental health services and help with basic needs, and that accessible and non-judgmental care was very, very important. Right now, we've been looking at sort of a literature review of other qualitative studies with people who use fentanyl, and most of them focused on why or were more descriptive. And so this study was a little more unique in that we also asked people what they think would help them, because they are the experts of their own lives, and they certainly some good ideas about what would be most helpful. So this huge table represents a question where we asked, what services would you want if they were easy to get? And we asked people if they were interested, not sure. And then there were some people who didn't respond. So, we showed people a list. We read these one by one. It's a really long list, but sort of summarize what this says is the top levels of interest. People were most interested in things like housing, cash assistance, employment support, phones, peer support, take kits, fentanyl test strips, safe supply, naloxone. So basically like a mix of basic kind of services and harm reduction. And also sort of interesting to note is there's a really high level of interest in contingency management for fentanyl use. Contingency management is program that is usually used around methamphetamine. It's one of the few sort of evidence-based approaches for methamphetamine. People receive small prizes or incentives for either engagement in care or negative urine drug screens. We asked people about this for fentanyl use, and people were very interested. Other services people were interested in, as we go down the list, generally healthcare was pretty high level interest. And the one where people were least interested and had the highest level of ambivalence were really around more traditional substance use disorder treatment, which is like one-on-one counseling, inpatient, and outpatient. And, this had the lowest levels of interest and highest level of ambivalence. But as you can see, like there's still a good chunk of people who were interested in those services. So big takeaway on this, people are interested in lots of things with a high level of interest in things to meet their basic needs, and either ambivalence or often negative feelings about more traditional forms of treatment. So we really need to think about what does care look like for this population, and how does that compare to what we have currently? So we asked people to describe your ideal place to get help with your health and or substance use. And our collaborator, Everett Maroon, in doing some of these interviews and listening to them and analyzing them, he's like, I feel like this is one where people all had really different ideas. And to really get the ideal place for everyone, you would need, a lot of different things. People's ideal place isn't just one thing. You'd need a place with like different options for different people. So I think that's a really good point. It was very individualized what these responses were. So we asked people what services and supports they would want. People talked about physical health care being really important, mental health care, that it was accessible. And what I mean by that is it had hours where they could get to it, that it was affordable, that there was easy transportation to it, or they could walk there, or that the care came to them. So accessible in many different dimensions. People also talked about the importance of having a sense of purpose, either by like giving back or through finding employment. People wanted activities, a whole bunch of different activities, often to sort of replace the role that fentanyl had in their lives. People really wanted other things to do. Help with basic needs was really important. Most of the people we talked to were unhoused. People brought up a lot, just needing help with the basics. Like one person talked about, oh, I drink water from a hose in someone's yard. So that's someone who really needs a lot and needs a lot of help. And so that's their priority at that point, is meeting those basic needs. A few people mentioned safe supply of opioids. So meaning a regulated supply of opioids that is in contrast to the highly variable supply of fentanyl, where, each time someone has a pretty high risk of overdosing because of that variability. And then some people talked about the importance of transition supports. So you finish a program and then what next? So things that can help you finish a program and then reintegrate into the kind of life that you want to have. And so I really like this quote because it speaks to both what people are looking for and how that is reflected in what they talk about. And this person said, just a place where you can calm your mind and relax and kind of be at peace. I think a lot of times, a lot of people, myself included, cannot be comfortable in the world or in our bodies or experiencing life. So just a place, a reason to be more comfortable with that, with less drug use or dependence on substances, to have that comfort, I guess. I think that really encapsulates how a lot of what people felt they needed was related to both their motivations for using fentanyl and for some of the drawbacks. So it's really important that we have programs that address those. Otherwise, whatever kind of program of care we have is unlikely very effective. So we asked people who the ideal people would be who would work at their ideal care center. People talked about mental health counselors, healthcare providers, social workers, and over, people talked about the importance of having people with lived experience who work there. So this says, to have somebody who has already been through it to show us that there is light at the end of that dark tunnel. One person just summarized, who should be there, and they said a psychologist, a doctor, the staff members, secretary, and the clinical workers, social workers, and providers. So really people wanted a mix of different types of service providers, usually at one location, rather than, just one type of thing. They wanted a place where they could address multiple needs with multiple types of providers. So we asked people about what the ideal vibe would be, as well as what the rules would be, and really the location. We put these together because they were very interrelated in how people talked about the place and the vibe. Many people describe wanting care in a homey space or even at home, that it should be easy to access and have flexible hours, and the rules should not be rigid. And oftentimes people were talking about what they wanted in contrast to a negative experience they had had in a healthcare or a substance use disorder treatment setting previously. So people would say, well, what I don't want is a program where, like this quote says, I mean, relax, not so pushy, more towards just trying to help, I guess, because some of these places you go in there and they're trying to push you. Nobody's going to do it unless they really wanted to. So there's no need to be so pushy. So often what people did want was in contrast to what hadn't worked for them previously. And in terms of the space, people talked about wanting cozy, homey, comfy, luxury, something like this. So that's not like a facility, but not an institution or something, but I don't know. I would just think a place should be like a house. You know what I'm saying? So you feel like you're at home. And then we asked about what the vibe would be. And this one person said the general vibe would be acceptance and love, and you don't have to hurt yourself to not hurt here, because all that is hurting ourselves out there. You're safe here. So really wanting a space where people did not feel judged, where they felt comfortable, where they felt safe. So a lot of those, just really wanting a really positive space where they could be in. And like I said, a few people talked about wanting care that came to them. One person was from a rural community and was like, I just would love to get care at my home with my family because they love me. So thinking about what our models of care look like, I think we need to not just think of a fixed location, but find ways to have options where care can go to people when possible and when that's what that person wants. So we did ask people about the medications for opioid use disorder. There's 3 FDA-approved medications used to treat opioid use disorder. Methadone and buprenorphine have a really strong evidence base, and we know reduce someone's risk of dying and reduce the risk of overdose and reduce cravings and withdrawals. The third one is naltrexone, also known as Vivitrol, which has less of an evidence base, but may be effective for some people. People were generally interested in methadone and buprenorphine, but really perceived significant barriers to accessing them. So Methadone you can only get it at an opioid treatment program. Often people have to go in 6 days a week to get methadone, and there are requirements to have counseling as part of that. So a much more rigid framework for how you can get methadone compared to pretty much any other medication. This person said, if they had a methadone clinic closer to my home, I wouldn't have to drive an hour and a half, 2 hours every day to get it. So, or if they gave out week doses at a time, that'd be cool. So talking about interest in methadone and then perceived barriers, but also ways, that they would like to see those barriers removed. Um, People were also interested in buprenorphine, which is also known as Suboxone, but some people perceived that there could be issues with precipitated withdrawal from buprenorphine, which is sort of a complex issue, but we think there may be needs for more education around buprenorphine for people who use fentanyl, and also looking at new models of how it's delivered so that that's an option for people. Buprenorphine is available as just a regular prescription, and there's options for, daily oral dosing, or now there's a new medication that's a once a month injection. So trying to understand what models will work best for people, and then, what is of interest to them. This person said, because the key is to not have to use anything else out there. And eventually, maybe not even need to use some of the things that are here, the Suboxone and stuff, but that's one step at a time. So people having that ultimate goal of not being on anything, but sort of seeing that Suboxone could be a good interim step for them. So this is our big discussion. These are the summary of our key points. People really reported a huge shift in the drug market from heroin to fentanyl around 2020, and that this had really big effects on their substance use and lives. As we were working on this, our colleague Susan Kingston kept saying, but how is this ever any different? So I put this in here directly. How has fentanyl changed the lives of people who use drugs? People are very afraid of overdose and death. I've done interviews previously with people who use drugs, and overdose came up very rarely as a concern. However, it was a recurring theme in these interviews. People are really afraid of dying from overdose. They've overdosed themselves and often have seen other people around them die from overdose. So this is really a situation where overdose is a really common concern, rightfully so, and it's really changed how people perceive their substance use. Another big shift was smoking rather than injecting. As we talked about, people perceived it as a lower risk for overdose, as it was easier to control the dose, that it was preferable to injection in general. And we really think future research should look into how to keep people safe from overdose when smoking and how to educate people about the potential risks of smoking. Really, the huge thing that kept coming up as we talked about this was we had a big gap between what people needed and what was available. And now with fentanyl, that gap is even bigger because fentanyl is very short acting. It's very potent. And so often people have even more, may develop opioid use disorder more quickly and may also have worse withdrawal than before. We had a opioid crisis before, and now it's just even worse. So really like a call to action that we need to start taking this very seriously and start to create care systems that can help people as soon as possible. So related to that, people said it was just easier to keep using fentanyl than it was to try and get substance use disorder treatment, that barriers to entry are high and options are limited. And some of this was due to doing interviews in more rural areas, but a lot of our interviews were done in Tacoma, so in one of the larger cities in the state. We just don't have enough options for people, and there's often it's way easier to go buy fentanyl than it is to get into a treatment system. And to sort of summarize what Teresa talked about, people have really complex reasons for using fentanyl that include physical pain, mental health, homelessness, and avoiding withdrawal. And that we really think people need a range of supports to address why people use and help them reduce or stop if that's what they're ready to do, which 70% were. So 70% wanted to reduce or stop their fentanyl use, and most people were taking steps to avoid overdose and stay alive, So many people expressed not wanting to die. Most people talked about things they were doing to try and stay healthy. People are doing things to try and take care of themselves, even when that's really difficult. So given that, we think that appropriate and accessible care could have a really big impact on improving health and reducing overdose deaths. This is a group of people who are motivated to improve their health, but experience huge barriers in doing so. So we think ideal care would be really holistic and that it would address medical needs, mental health needs, basic needs as much as possible, have be accessible in all those ways that we talked about, non-judgmental, and have medications available for people who want them. And we think that we should engage people when they're ready for services, not just when they're ready to quit. So many programs are focused on reducing or stopping someone's substance use, but the people we spoke with had other needs and concerns. So providing a space where they can address those other needs and concerns and then stop or reduce their use when they're ready. So, similar to other chronic conditions, see people, help treat their different concerns rather than just to focus on abstinence from substance use. So our recommendations are to treat fentanyl as a serious public health crisis, that we need to listen to people who use fentanyl and ask them what they think would help. That health programs should be accessible for people who use fentanyl. We want to meet people's basic needs. We think provision of safer smoking supplies is really important given the huge shift in how people use. Increase access to an education about medications for opioid disorder and to consider safe supply of opioids so that people have a better chance at not overdosing so frequently. So limitations, this was a convenience sample. Majority of people were unhoused, so may not be representative of other groups. Majority of people were men, and the interviews were conducted in Washington state and may not be relevant in other parts of the country. So this is just our big thank you to, Everett, who worked with us on this, to the Healthcare Authority for funding this, to all the programs we worked with, and most importantly, to the people that we interviewed who really shared their knowledge and experience with us. And if you're interested, you can download our summary for a nice summary of what we learned. And then this is just our slide for where you can go to learn more. So I think we're ready for questions. We have 8 minutes left for questions.
Perfect. And if you put the link to that summary, then I can put that in chat for people to access. So the first question, did participants give any info on how they reduce risk of adulteration in their fentanyl supply? Was xylazine and other adulterants in the supply here in Spokane helping folks avoid that added risk is a priority?
No one was talking about xylazine at the time these interviews were conducted in September. So no.
We didn't hear that a lot in our interviews. People weren't talking, they weren't talking about xylazine, and we didn't hear too much about kind of how they were trying to assess and control the supply. I think that strategies are fairly limited. The ones that Allison mentioned regarding kind of reducing risk for smoking, doing a test hit, making sure you don't use alone, using in smaller quantities. Those strategies people did talk about, but as far as xylazine is concerned and other adulterants, we didn't get much about that.
Thank you. So the next question, based on your research, when do you think is the most effective time to engage someone with help? When/where they're using, after they've overdosed, during an encounter with emergency services, after?
I think it's most likely to be effective to engage people when you're prioritizing what they care about, which is not necessarily after an overdose. People probably feel pretty crummy. I think there's good things to offer someone after an overdose, but it may not be the best time to talk to them about their substance use. What we really found is it's best to offer care, make care available when they want care.
Yeah, and then we just heard so much of that desire for care, right? So So the idea that, people that are using fentanyl don't want care and access to treatment is just not true. But from this population, from this project, we heard just incredible documentation that people are struggling with their fentanyl use and do want access to ways to improve their lives and address their substance use.
And that they want it from a provider that they trust, who's not going to be a jerk to them.
Yeah.
And have lots of have really rigid rules that make it hard for them to stay and care. So I think it's more about the place and the people and the range of what's offered than a specific time.
Perfect. Thank you. I've heard naloxone isn't really as effective with fentanyl users. Is this true?
No, that is not true. Naloxone is still highly effective for fentanyl use. Likely it still only takes one dose. Maybe it takes a second dose. The big difference is the time frame. Fentanyl overdose can happen much more quickly. So you don't want to wait around and see if the person is going to wake up. If someone is non-responsive, if you've tried a sternal rub or an ear pinch and they're not responding, give naloxone. It should still work if it hasn't been too long.
I've heard Washington State has the highest overdose rate in the nation. Is this true?
Do you want me to take that one, Teresa?
Yeah, go for
I
it.
know the data. That is not true. Washington generally has been in the middle of the pack. Washington has seen the largest increase in overdose deaths in the nation. And the reason for that is sort of complex, sort of not, but that the East Coast saw fentanyl much earlier than we did. We really have just seen fentanyl introduced in the last few years. So places that saw fentanyl introduced saw their overdose deaths jump and then increase, but more slowly. And the introduction of fentanyl here is what really has skyrocketed that rate. So we've had the highest increase, but we don't have the highest number or rate of overdose deaths.
Yeah, and I think the only addition there is that there are places where the overdose death rate is not increasing, and in Washington it is increasing.
In Rhode Island, it dropped. So
yeah, and I think other places too, yeah, but not here.
So this is the last question that I'm seeing. If anyone else has questions, please be sure to put those in either the Zoom chat or Whova Q&A. How much would controlled dispensing of fentanyl reduce overdose?
It's hard to predict that, right? But like, if you think about the risk that people are navigating in using an unregulated and really dangerous drug supply, if we switch that out and have a regulated drug supply, of course, the risk goes way down. So we, I don't know that we have a predictive model to answer that question, but a huge impact. Allison?
Yeah, and I think it would be ideally as part of a suite of approaches where you're offering people a range of things. I don't think we have an exact number, but one sort of comparison is one cohort of people nationally who've seen their overdose rates increase really dramatically is older Black men who've been using heroin for a long time. People who've been using heroin maybe since the 70s or 80s, who knew how much they could safely take, were not dying. Now fentanyl is around. These are people who have a long period of experience with opioid use, and fentanyl is killing this group of people at a pretty high number. So having a known amount can help people reduce their chance of dying. It's not a perfect solution, but it would certainly be effective at reducing overdose deaths in the situation where we are now.
There's just one more question that came through, and this will be our last one since it's almost 2:30. Did participants talk about safe consumption sites and how that might impact their use?
We had a couple people mention safe consumption sites, but it didn't come out as, we didn't ask about it except for in our services list. Specifically, there is a new study happening with ADAI that's about safer supply. So that is something that in the future, in the near future, you can look for resources about that through ADAI, but not in our participant transcripts as much. Allison.
Yeah, people didn't talk about safe consumption space very much. That doesn't mean if we did not ask about it specifically. We really were wanting to know more about like ideal care and healthcare. So it's larger comprehensive question. So it's hard to say what people would have reflected on for that.
Yep.
Wonderful. Well, thank you both. It's 2:30, so we'll let everyone move on to the next session. Very much appreciate you spending some of your afternoon with us and for sharing all of your insights with this new research. Thank you both so much. And thanks to everyone who attended and asked some great questions.
Thank you.
Thank you.
Bye, everyone.
Bye.